Okay, so any questions from last week's material? You guys haven't looked at it, so it's okay. You guys, that or you've got it all down already. That's perfect. Okay, there you go. Maybe this will be some good reinforcement for you guys. So we talked about hormone replacement therapy. We talked about some ways to do that. Now we're going to move on and talk about the oral contraceptives. So when we are giving oral contraceptives, we are using combinations of estrogens and progestins. Why do we do both? They have a uterus, yes, right? Because these are people of childbearing potential most often, and so you want to, usually they have an intact uterus. So again, we combine the progestin along with the estrogen to prevent that kind of unopposed growth of the endometrium and try to stunt that. So anyway, so then when you're having these products being given, they can come in several different formulations. There's so many different brand names and varieties that are out there. It's frankly quite bewildering, but you can find some that will be monophasic, biphasic, and triphasic. And why do you think there's the different phases? Or what do you think the difference is between those? They change the dose.
To mimic the actual cycle.
Precisely, yeah. So the more phases you have, the more closely it's trying to mimic what the actual menstrual cycle looks like in regards to how estrogen and progestin levels will change throughout the month. Monophasic, obviously, being the least like a normal cycle, it's just going to have the same dose of estrogen and progestin throughout the entire phase. And then when you're looking at biphasic and triphasic, they're changing. Usually biphasic, you're going to have one change in either the estrogen or the progestin or both components, and then in the triphase you're going to have two changes throughout the month, right? And then what's the last 7 days of any birth control pack? Placebo pills, right? And why would we do placebo pills?
To
keep them on track, right? You want to make sure people are taking the same pill every single day, and that helps to prevent people from missing doses. And we'll talk a lot about missing doses later on, because what's the biggest problem with missing doses?
Having a baby.
Getting pregnant, right? When you don't want to be, that could be a big problem. So this is why we worry about missing doses and make sure they try to be consistent with this. You will find that you can get away with just using continuous progestins for contraception. We'll talk about some problems and benefits to that. So here with our mechanism, we're having the selective inhibition of pituitary function, because remember, we're having that negative feedback loop. Your body is sensing that, hey, we have a lot of estrogen, we have a lot of progestin around. I don't have to necessarily be releasing a lot of FSH and LH because I've already got enough estrogen around. I don't need to be spitting out any more of that. So that's basically how you're shutting that down via those negative feedback loops. With the combination agents, you're going to be seeing certain changes occur. So you can have changes in things like the cervical mucus, the uterine endometrium. You'll find that the motility and secretion of the uterine tubes is usually limited to some degree. And all of this is kind of leading to kind of an inhospitable environment for implantation of a sperm and egg to occur, right? So basically you're preventing ovulation, hopefully preventing that pregnancy from occurring in the first place. You will find that progestins alone don't always inhibit ovulation, so that's why you're going to see that, especially with progestin-only products, your risk for failure is going to be a little bit higher than you're going to see with combination products, right? Because are any of these drugs 100% effective? No. There's always going to be a small chance that they could fail, and what also is usually making them more likely to fail? People, right? So no one's going to have 100% accuracy forever. You know, some people screw up and they miss doses and things like that. So typical use, right? So you got to think about what's the typical use, make sure that they are aware of the possibilities of what happens when they don't take it, and make sure they're using things like backup methods where appropriate. So some of the other effects you're going to be seeing with the ovaries, you're going to have depressed ovarian function, right? So they typically become smaller during therapy. You'll find that most patients end up returning back to normal menstrual patterns once they're discontinued, right? Doesn't matter how long you're on the oral contraceptives for. Generally, people go back to normal somewhat quickly. You'll find about 3/4 of people will ovulate during the first cycle. When they come off the contraceptives, usually about 97% by the third round, which is usually fairly quick. But some people may remain amenorrheic for several years. So just keep in mind, some patients may be more or less prone to that, depending on kind of what their previous history might be. With the uterus, what you can see is some hypertrophy and some polyp formation, and usually a little bit thicker, less copious mucus ends up being formed. Again, kind of making it less likely for things like sperm in order to make it to the egg. Due to the estrogen effects, you can see breast enlargement, also will suppress lactation, and then you will see some hematologic effects as well. A lot of this is going to be related back to the estrogen effects within the liver, and we always worry about what occurring in these young ladies when they're taking contraceptives. clots, right? Because in the liver, it's stimulating those, especially the orally administered contraceptives. You're stimulating clotting factors like 2, 7, 9, and 10 to be more prevalent. Unless you have more clotting factors, more likely to clot. You also have decreased activity of antithrombin 3. You guys remember what drug uses antithrombin 3 to work better? Warfarin prevents production of 2, 7, 9, and 10. Heparin. Fondaparinux will do it as well. But remember, heparin works with antithrombin 3. It makes it catalyze that reaction even more quickly, right? So those work in tandem. And so that's where we get a lot of this thromboembolic concerns for these patients. You can see some skin changes, so hyperpigmentation is a possibility, especially those who have darker complexions already, and you can see, especially if they have exposure to a lot of ultraviolet light.
Is the increase of is that due to the hormones or the metabolizing, something happening during metabolism in the liver?
It's due to the effects that the hormones are having on the liver. So as they get processed through the liver, because again, if you think about the first place that a drug goes to after it gets absorbed, it goes to the liver, right? So those hormone effects increase clotting factor production. Yep. That's where we're also going to see things like the cholestasis and whatnot come from, is due to those liver effects. Yep. So hyperpigmentation, and you can also potentially see some androgen effects from the progestins specifically, and that can cause increased sebum production and potentially worsen acne. For some people, you will find that their acne gets better on contraceptives. For some people, it may get worse. A lot of that may go back and be related to the androgen that they're using. We'll talk a little bit more about that, but remember that not all progestins are going to be, whatever progestin they're using. Not all progestins are created equally. Some will have some androgen receptor activity, some will have some mineralocorticoid activity, and so that's going to change what some of your side effects are going to look like. So obviously the biggest use for this is going to be for contraception. The risk is pretty small if you take it according to the proper directions, which is usually one pill per day. Looking at combination agents, if you were to look at typical use, as we kind of mentioned, it's about 5 to 12 pregnancies per 100 women year. So if you had 1 woman for 100 years, or if you had 10 women for 10 years, you'd have about 5 to 12 pregnancies with their typical use. If you had perfect use, so every one of them was being given at gunpoint or something, you would have about a half to 1 pregnancy during that time period. I don't know what a half pregnancy looks like, but you might have one. Anyway, yeah. So this can be affected by things like drug interactions. So you can have some drugs that can actually affect the metabolism or diminish the half-life of some of these drugs. They get cleared more quickly, and so that can also increase your risk for developing more risk for pregnancies. So if you think about things like enzyme inducers like phenytoin and a lot of other neuroleptics that we use, anti-epileptics we'll use for seizures, those can induce those enzymes. If you have things like antibiotics, which are kind of screwing up the normal GI flora, that's usually used in order to cause that enterohepatic recirculation. You guys remember what that is? Right, so these hormones get kicked out by the biliary tract, they'll get metabolized by those bacteria, and then they get reabsorbed. If you get rid of some of that GI flora, you're not going to have as much of that recirculation happen, and you can have levels get driven down, and that's more risk for pregnancy. Okay, so that's why I always worry about, or I always tell patients, make sure they use a backup method while they're on antibiotics to make sure they don't have any kind of effects from that. You can also use this for endometriosis. So you may find that estrogen alone can be sufficient to alleviate pain, but again, you do want to have that progestin on board as well to kind of prevent that hypertrophy there. You want to use the lowest amount of estrogen possible because this will help to limit some of those other adverse effects, which we'll talk more about in detail in just a little bit. So those adverse effects, mainly the most common things you're going to run into include things like nausea, mastalgia, again from the effects of the estrogens on the breast tissue. You can see breakthrough bleeding, some edema. Where do you think the edema comes from? Salt retention due to not the estrogen necessarily. It's the progesterones usually, right? Because a lot of them will have mineralocorticoid effects, and that causes water and salt retention, right? So that's where you can see a lot of the edema coming from that standpoint. So you can actually find that using something that has like a mineralocorticoid antagonistic effects, sure, some progesterones will do that. You may actually have kind of neutral effects on weight. They won't have as much edema developed there. So you find things like breakthrough bleeding, it may be more prominent though if you have like too much estrogen on board. So you can find that by limiting the dose that they're receiving of the estrogens, or potentially using progestin with more androgenic effects, so you can kind of limit some of the things like breakthrough bleeding you're having there. Headache can be occurring here as well, but of course, some women, you will find that if they have migraines, that actually can be helped by using oral contraceptives. Some of it will make it worse potentially. Yes, sir.
I thought the breakthrough bleeding was fixed by the estrogen.
You'll find that it depends on when it's occurring. We'll talk about that a little bit later, how you can kind of, depending on when the bleeding is more likely to occur, you will find that by changing your dose of estrogen or progestin, you can modify that to deal with that breakthrough bleeding. So that'll come back in a little bit later. Obviously, if you were to have a patient who started their oral contraceptives and all of a sudden start complaining about really severe headache, what would you be thinking about? It should be a problem, right? If you want to switch your medication, what was the thing you want to rule out? Like they're incapacitated by how bad this hurts. Sudden onset. Yeah, like a stroke or a bleed or something like that. So usually you're going to see more ischemic kind of complications from this due to the clotting effect. So again, those are the big things you want to be cognizant of. And they say, hey, if you develop severe headaches on this, like maybe we need to look at switching the product and make sure you're not having any kind of other more serious issue going on with that. And then you may find that some patients, when they're coming off of their contraceptives, they may have withdrawal bleeding that fails to occur. This can be problematic because they may think that they are pregnant, right? So that could be something you may need to reassure them about. If this becomes problematic, so say every time they go on their placebo week, they don't have that withdrawal bleeding, you may be able to switch them to a different product and get rid of that, right? Because again, when you stop your contraceptive, you want to have that reassurance of withdrawal bleeding, so that way you know everything's working like it should be, right? You don't want to think every time that, oh, I may be pregnant, and you spend a lot of money on EPT, and that's just no good, right? So my wife, when we were initially trying to get pregnant, she ended up buying a ton of, she likes to be kind of frugal, some may say cheap, but she ended up going to the dollar store and buying out like every pregnancy test they had there, and she's like, it's not the first response, it's the last response, because we got the dollar store brand version. So anywho, so maybe sometimes you get what you pay for. Anywho, some of the more moderate adverse effects you can see with these products, you can have more breakthrough bleeding. It can be a little bit more severe. You will find that this is more likely to occur with progestin-only products. So about 25% of those patients end up having some breakthrough bleeding issues. You will find this also occur in low-dose preparations as well. You'll find that we like to use as small doses of estrogen as possible, but if you go too low, you also worry about some of those bleeding effects. And you can see that sometimes you can get away with using a lower total amount of estrogen content by using biphasic and triphasic products, where they end up kind of ramping up the estrogen dose towards the end of the cycle versus using a lot of it at the very beginning. We don't really need it quite so much. The weight gain, again, is going to be more common with androgen-like progestins. A lot of it's due to those mineralocorticoid effects, where you can see more water retention. And so you can either have them switch to a less androgenic progestin, or things like dietary interventions and whatnot to fix that. So again, we mentioned the increased pigmentation. You will see that this can increase with time. So about 5% at the end of the first year, and about 40% of women will experience this at the end of, say, about 8 years. So this can be something that may be reversible, but it can be kind of slow to occur. And those that are vitamin B deficient tend to be more susceptible to this for whatever reason. And then, like you mentioned, the acne, this can be worsened by the androgen-like progestins. So more androgen effects, more likely to see acne from that effect. And using large dose estrogen for some patients may actually improve this. Okay. Other things you may see, things like hirsutism. So you may be, this could be aggravated by androgenic progestins. So again, you can switch to one that has less androgenic effects in order to help limit this. Some patients, you may have this ureteral dilation, which can be kind of similar as to what happens in pregnancy. This will make them more prone to UTI, so that could be something to just be aware of. And then the amenorrhea, you can see this certainly with the progestin-only products. But again, they're more likely to occur in those that had kind of prior menstrual irregularities beforehand. A lot of those patients may end up having kind of an undiagnosed prolactinoma, and that can be kind of exacerbated by this. And then the very severe things we worry about, is obviously venous thromboembolism. So again, the risk ends up being about 3-fold higher while on low-dose oral contraceptives than if you're on nothing alone. And so you're going to find that the risk is increased during that first month and kind of stays consistent all the way throughout. When you remove it, obviously your risk goes back down to kind of your baseline, right? So as soon as you don't have that estrogen effect on the liver, you're going to lose a lot of those extra clotting factors and you kind of go back to baseline risk. Obviously, those that have kind of an undiagnosed hypercoagulability beforehand are obviously at higher risk, and so that's oftentimes where you kind of discover those things, like if they have any kind of factor issues or factor V light and things like that. That's usually where you end up diagnosing that. Secondary to the clotting risk, you run into things like myocardial infarction. So you can see things like those patients who are higher risk, things like diabetes, hypertension, they're obese. Obviously, they're smokers, so that's one of the big things. If you're putting a patient on oral contraceptives, tell them to stop smoking, because it also increases the risk of clots and MI. So just be aware of that. Make sure they're taking all precautions to avoid some of these more severe reactions. Again, similar with the cerebrovascular disease. And then the gastrointestinal effects, again, are related back to the liver problem. So things like cholestatic jaundice, more likely to show kind of in the first couple cycles of therapy. And you will notice that, if they do develop things like jaundice, pruritus, that usually resolves within 1 to 8 weeks or so after discontinuation. So this is more seen with the oral products, so you may be able to switch them over to something that's, say, parenteral in order to help avoid some of this. So something like, an intramuscular progestin or something might be a better option for them. Some patients may have depression associated with initiation of oral contraceptives, so some of them will require discontinuation. So again, figure that out. If they have underlying depression that was maybe not diagnosed previously, this could be kind of the big manifestation of that. And then cancer risk as well. So typically you end up seeing a reduced risk of endometrial and ovarian cancer for these patients, but you may have you end up seeing kind of lifetime risk of breast cancer probably being not really effective so much from this standpoint, but you will have increased risk of cervical cancer, and those are the HPV, unless they got what vaccination? Yeah, Gardasil is a big one. So if you can hopefully prevent HPV in the first place, you can get rid of a lot of the cervical cancer cases. So here's some the different progestins you may run into and kind of what their different kind of effects will be based on their receptor activity. So you can see the first generation products here. Things like norethindrone, norgestrel, norethindrone acetate, like these are seen very commonly in a lot of, especially the cheaper, like generic based oral contraceptives. You see they have some estrogenic effects. Then you see kind of the progestational effects are going to vary, and then these are probably going to have the most of the androgenic effects you're going to run into, at least clinically. You'll leave norgestrel, which you'll see in some cases, which has a lot of androgenic effects. So you may see that worsen acne, the hirsutism, things like that. But then as you get into higher generation progestins, you end up losing a lot of that. So things like norgestimate, drospirenone is actually probably one of the better ones to start a lot of patients on. This is found in like Yaz and Yasmin. A lot of patients like this because it has androgen receptor antagonistic effects, has anti-mineralocorticoid effects. So you lose a lot of those side effects from that standpoint, which is why a lot of people end up recommending this drospirenone containing products. Usually end up being a little bit more expensive, but if their insurance covers it, it's usually a good option for a lot of patients. So, contraindications and cautions. So again, if they have any history of cerebrovascular disorders or thrombophlebitis, cardiovascular disease, be cautious in these patients. Obviously, any unknown cause of vaginal bleeding you want to be careful of because you're worried about cancer, right? So you want to make sure that's not a problem. Estrogen-dependent tumors, obviously, you want to avoid. Heart failure. Why heart failure? That'd be a caution. You don't want to kill them, true. Why would this kill them potentially? Yeah, the water retention is a big thing there, right? So the edema and whatnot, that can potentially worsen their CHF. So you want to be careful with that. You do worry about some premature closure of the epiphyseal plates in the bone. Be careful with that. There is some small risk of growth stunting they worry about with estrogen. So again, usually after patients have hit puberty, and it's usually the better time to start that anyway. Be careful with hepatic enzyme inducers like rifampin and phenytoin. Again, that's going to end up driving your levels of the contraceptives down, which can lead to accidental pregnancies. Be careful with antibacterials. As I mentioned before, it interrupts that enterohepatic recirculation potentially. And obviously pregnancy, you do not want to start these medications for a pregnant patient. They've kind of already failed at that point, right? Okay, so looking at progestin-only contraception, this is going to be better for patients in whom you do not want to start estrogens in, and it's nearly as effective as the other combination products. You do end up finding a lot more incidence of higher normal bleeding. Usually this gets better with time, but amenorrhea can be very common with a lot of these patients. Usually end up seeing kind of the most common ones end up either being like the progestin-only kind of mini pills, but they also have like the Depo-Provera, which is the medroxyprogesterone that gets injected in as an oil into the muscle, and that actually lasts about, you guys know how long it lasts? About 3 months, yeah. So you end up having cases where you can put a patient on that, you think it lasts to 3 months, but they don't actually, 3 months and 1 day, they don't just start ovulating again, right? With a lot of those products, you end up having delayed return to ovulation. So if you have patients who are looking to get pregnant within like a certain time frame, let's say like, okay, we want to be married for a year and then we're going to try to get pregnant. Progestin-only products are not the best ones for that because they can have a delay in getting back to that point where they can start to try again. So. Next, you have the postcoital contraceptives. So these are going to be like the morning after pills. You can find that some of these will be estrogen-only products, progestin-only, or combinations. Most frequently, you're going to find progestin-only products are going to be recommended here. So these are about 99% effective if they're used within 72 hours of sex, right? So earlier, the better. So you want to encourage your patients to make sure if this is something they want to pursue. They don't want to wait 2 weeks and be like, all right, now I'm ready. It's like, it's not going to work so well, right? You'll find that these products also cause a lot of nausea and vomiting, so you probably want to recommend some sort of antiemetic to go along with this in order to help prevent them from throwing it back up, right? Because again, if they throw it up, then they got to take another dose, and it's kind of fighting themselves at that point. If they throw up within an hour, you do want to repeat the dose. If it's past an hour, they've probably absorbed enough of it to not be a problem. Okay, the most common ones you're going to run into include levonorgestrel. This is like the Plan B one step, where they only have to take one dose. Here you have one that's a smaller dose. They end up taking twice daily for 1 day, so do 12 hours apart. And that way they end up getting the same total dose, but it may be easier on the stomach for them. Do you need a prescription to get Plan B? Not anymore, right? So for several years now, we've been able to get this one over the counter, or at least from behind the counter from the pharmacist. Some of these you may still see being used. Have you guys ever heard of using someone's oral contraceptive pack as a morning after pill? Okay, so I had some questions from a different class, and they were curious, like, how do you do that? So what used to be recommended, I did some research on this, is that you could use multiple pills out of an oral contraceptive pack in order to get the same effect as getting like a Plan B, right? So instead of them, if cost is an issue, or for, there's a reason why they cannot go out and get one of these products, like they can potentially use their own birth control for it, okay? It's not recommended as much anymore because we have super effective products like Plan B. We don't have to worry about that, and so it's not super recommended, but one thing you could do is essentially you end up taking enough pills in order to get 100 micrograms of the estrogen and 0.5 milligram of progestin. Okay, it doesn't matter which ones they are, and then you do that 12 hours apart for 2 doses. So in case anyone's ever curious about how to do that, that's what has been recommended in the past. Okay. Any questions on that? So again, earlier the better. Watch out for nausea, vomiting. All right. Some other beneficial effects you can see from hormonal contraception: reduced risk for things like ovarian cysts, reduced risk for cancer of the ovaries and the endometrium, can reduce risk of things like ectopic pregnancies, iron deficiencies. Why do you think this might help with iron deficiencies? Less bleeding, right? So they're holding on to more iron, absolutely. Potentially reduced risk for rheumatoid arthritis. I have no idea why that one is, but that's one thing. Like I mentioned, some patients may have their acne improved. Hirsutism may be improved for some patients, especially if you use less androgenic progestins. So lots of different reasons why a patient might be on oral contraceptives other than strictly for contraception purposes. So, yes, ma'am. Mm-hmm.
You said that an increased risk of oral contraceptive is cancer?
So when they've done kind of like the long-term studies, they've mainly found that like the breast cancer risk is pretty much not affected. Endometrium and ovarian risk goes down, but the cervical risk can go up if they have concomitant HPV.
Concomitant HPV?
Yes.
Okay.
That's what they found. Yeah, so that's why like you recommend like Gardasil. Hopefully they don't get HPV for those strains that are more likely to cause cervical cancer. Does that make sense? All right, sweet. Okay, so if you're starting out a patient on oral contraceptive, typically start with the combination pill. These are going to be best tolerated for the most part. They're also going to be the lowest risk for failure if they're using the pills every single day. And you want to use the lowest effective estrogen content possible in order to avoid some of those side effects we'll talk about, or we have talked about. Basically, you have to kind of figure out what the acceptable level of side effects are going to be for them, and if it's something they can tolerate, or if it's something you may want to switch over to a different type of product. And typically, you want to give them a 3-month supply just to kind of give them a couple cycles to figure out how they like it, see what kind of side effects are, and then you can kind of make a better decision on if you want to stop it or switch over to something else. Okay, so how do you start oral contraceptive? What day of the week should you start it on? Normally, you're going to start on the first Sunday after menses. Technically, you can start it whenever you want, because at that point, you're kind of restarting the cycle all over again. But by starting it on a Sunday, you typically avoid withdrawal bleeding on weekends. So that can be beneficial for your patients. They want to, again, we don't want them to try to impact their normal life as little as possible. So usually people like to go out and do things for fun on the weekend. So hopefully that's better for your patients. If it's post-pregnancy, typically they recommend it about 3 to 4 weeks post-delivery. Keep in mind this is going to suppress breast milk lactation. So again, you're going to, obviously they're probably going to be on formula, things like that. And if they were to be post-abortion, usually they recommend the first Sunday afterwards in order to again start their cycle back over. So when should you use alternative methods of birth control? This is not going to be 100% absolutely the case. This is just kind of what general recommendations are going to be. Some people may recommend using it for the initial cycle. Technically, you don't have to do that. The risk is still pretty low for conception to occur, but some people will still recommend until you kind of get into a normal groove of things, perhaps use backup method for that first month. Okay. Again, if your patient does not use backup method, are they absolutely going to get pregnant? No, but the risk is going to be lower. The lower the estrogen content they're taking, the more pills that they miss, the more likely you are to have failure. So we'll talk about how to make up missed pills, but that could be another indication to use backup forms of protection. They're having severe diarrhea. Why do you think that would lead us to use backup methods of protection? Well, yeah, because again, if you're clearing it too quickly, you're not absorbing quite as much of it, so you may have your levels drop, and you may see risk for failure. Antibiotics very similar as well. You're never going to find a paper that says like absolutely if you're on antibiotics you have to use backup methods. But again, this is one of those things where like if it was me, I'd rather be safe than sorry, right? Probably. I like to be risky in some things, maybe driving, but not when it comes to. Yeah, it's not something you want to do. Anywho, so what do you do if you miss a pill? Okay, if you miss a single pill, take it as soon as you remember, right? Or if a patient calls you and says, hey, I missed a pill, what do I do? They're freaking out. Say, hey, just go ahead and take it as soon as you remember, okay? If they miss 2 pills, have them take 2 a day for 2 days in order to catch back up to where they were normally, okay? That make sense? Miss 2 days, just have them double up for 2 days, and that way they're back on track where they should have been. If it's 3 or more, at that point the risk for failure is too high, so what I would go ahead and say is use backup forms of protection if needed. Discontinue the rest of that pack and just chunk it, and then restart on a new Sunday. Okay, so probably have withdrawal bleeding in the meantime, but then they can restart and go back on to their normal kind of cycle again. Okay. So if they have missed periods or they're having this failure of withdrawal bleeding, again, most women will probably jump to thinking what conclusion? I'm possibly pregnant, right? So if they've had no missed pills during that time and they're honest with you and forthright and say, hey, I actually didn't miss any kind of pills whatsoever, I'd probably say get a pregnancy test after the first missed period. If it was like twice that it happened, go ahead and check it again. If it happens the second time to see if you're pregnant or not. A lot of times it may be too soon. Those HCG levels might not be high enough to really trigger those assays anyway, so it may not be able to pick it up. There are ways to reschedule the menstrual cycle. When I learned this, I thought it was black magic, but this is actually just chemistry and just normal physiology. But there's this phenomenon called honeymooning, where basically you can kind of reschedule the woman's period to make sure that she is not on it during an event that she does not want to be on her period on, right? So if you're on your honeymoon to Cabo, or if you are spring break, or whatever it happens to be, you can basically reschedule. And what you would do is have the patient continue taking active pills until the event is passed, and then have them start a new pack. Basically, they would just go to the placebo portion at that point, and then that would trigger their menses, and then you can start all over again. Okay, so just tell them, hey, skip out on the placebo stuff that last week. Don't worry about taking it. Just start a new pack and keep going until after the event, and then you can start it anew. Okay. Typically, for stopping pills, you don't really need any kind of like rest periods or anything like that. Like not like the body gets too used to the hormones or anything like that. Things typically go back to normal as soon as you discontinue it. But if you do have a desire to become pregnant, usually allow for 3 regular cycles or so prior to conception. That way, again, most people will kind of be back ovulating at that point, and then your risk for success is going to be a little bit higher at that point, right? So again, if they don't get pregnant during that first month and they're coming off of it, tell them not to freak out. It could just be their body's getting back to normal. Especially if they're on a progestin-only product, that's going to be one of those ones where they may have delayed ovulation, and so they may need to wait even longer than 3 months. So, okay, so looking at breakthrough bleeding, which can be a common phenomenon here. If it's happening during the first 3 months, it generally resolves over time. It gets kind of better as the body kind of gets used to things. If it's still present after this, you can actually manipulate the medications they're taking, the doses of either progestin or estrogen in the product, and switch them to something different based on when the bleeding occurs. So if the bleeding is happening on the first 2 weeks of the cycle, typically that is going to be indicative of an estrogen deficiency, so you can actually bump up their dose of estrogen in the product in order to overcome that. Okay, if they're having bleeding on, say, days 15 through 21, that's typically going to be a progestin deficiency, and so if you bump that up, then that would hopefully take care of that. So I actually had this question come up in the ER of all places. I had the ER doc who called me up, and he is this big, like, 6'5", like, guy from Kentucky. He was like, I don't even know what to do with this patient. I don't remember how to treat girls' periods, and very much out of his realm of comfortability. And I was just like, well, I'm not in it either, buddy. But basically, he said, hey, she's having bleeding. What do I switch her over to? Because obviously your birth control is not working. So I said, well, when is she having the bleeding? And sure enough, it was during that first kind of 2 weeks of the cycle. So I said, okay, well, let me look up a product. Found one that had a higher estrogen content than what she was taking already. And then they wrote a prescription for that, and hopefully that would have dealt with it. Okay, so just consider the timing of it and what that could be indicative of. All right, so some other miscellaneous products you may see being used for contraception. So you have medroxyprogesterone acetate, or this is the Depo-Provera. Anytime you see Depo on a drug name, that usually means it's a long-acting formulation. So here is an intramuscular injection that lasts about 3 months. Again, this is, what type of patients do you think this would be good for? Non-compliant patients, right? So if you think about like, patients who have like severe like psychiatric issues, that, especially those like bipolar disorder, that may be more prone to like promiscuous behavior and things like that. If you want to make sure they are, what are you pointing at your stomach? Yeah. So absolutely. So they have liver problems, or if you're worried about them having a thromboembolic complication, like this would be another good product for them to try. If a person just does not want to take a pill every single day, this could be a decent option for them as well. Again, keep in mind the duration of effect is going to be about 4 to 6 weeks longer than just the 3 months that it's there. We just do it every 3 months to make sure the levels are kind of topped off, and to make sure that they have low risk of failure with this one. But again, we'll have delayed onset to ovulation, so they need to be aware of that if they're planning on getting pregnant. And amenorrhea is very, very common with this. So they can have kind of irregular patterns, amenorrhea being the most common one. Okay, so some other products you can see being used. So we have levonorgestrel, which is that an estrogen or progestin? Yeah, it's a progestin product, right? So this is called Mirena. This one is, you can see the device here, kind of being planted right past the cervix into the uterus, and you can see where it is basically has drug implanted along these little prongs here, and they will elute out this levonorgestrel. Big benefit here, lasts 5 years, right? So it can be a nice thing for patients. Yes, sir.
Earlier you said that this one is correlated to more androgen effects. So
Can be.
would that mean that these girls would have more like herpes?
Look like bodybuilders. No, no, because it is a local effect, they're not seeing a ton of systemic absorption. Because again, this is a very kind of localized effect that you're seeing here, which is the benefit of it not being given systemically, right? So again, you lose a lot of those liver problems you run into, you lose a lot of these other issues you can see with those. And again, 5 years worth, so again, they don't have to think about it for a good long time. Usually you're going to find return to ovulation can be kind of variable. I think it's usually pretty normal for them to kind of get back on the cycle pretty quickly, just because it is so localized, and then when you remove it, the drug's gone, you're kind of done at that point. Okay. You can also have rings that can be implanted. So this is a combination product called NuvaRing, which is ethinyl, estradiol, and edonogestrel. And so basically this one is going to be more of kind of like a monthly kind of product, where basically you can implant this. Basically the patient would do this themselves, 3 weeks in, 1 week out, and that way they can simulate kind of a normal period at that point. Again, this one's usually kept in the fridge in order to make sure that the product stays kind of maintains its integrity. But see, plenty of patients who go on this, and again, it's nice because they don't take a pill every single day. Just kind of put it in. If it falls out, like during sex or something like that, they can just basically put it right back where it was, and then you're kind of good to go. I'm sorry? Not sure of any period you have to wait necessarily.
No, like if it falls out from intercourse.
I'm not aware. If you find something, let me know. I can include that. Yeah, you want to put it back in because you want to make sure that whatever it may be there is not going to implant itself. Make it all permanent resident. I also like this one. This is kind of the special bougie version that you can buy if you like. You gotta have really good insurance for this one though. Okay, you can also have some implanted products like here. So this is an etonogestrel. This one would be a little bit more systemic absorption that you would see from this. So again, more systemic effects you could expect, but this one would be given every 3 years and would be implanted by a provider. Again, with it being a progestin-only product, you're more likely to see irregular bleeding and whatnot, but that's another option for some patients. This one's kind of interesting. This is a Paragard, or a copper-based contraceptive. Essentially, this one is placed very similar to what the Marina was. Again, this would be implanted by the provider and is changed out every 10 years. So again, if you know you don't want to get pregnant for a good long time, you're not really at that point where you're going to be transitioning to menopause in the next 10 years, this is a great product for those patients. Basically, by having kind of slow release of copper in the area, you kind of make it very inhospitable for implantation, so thus it provides contraception from that standpoint. So if you want to really use basically no drugs, and you just have a little bit of copper there, then you're fine from that standpoint. You don't have to worry about going through customs or anything, or getting triggering off any metal detectors. It's a very small amount of copper.
Are we not worried about the fact that we're putting a heavy metal inside the body?
So I don't know of any kind of chronic issues. Certainly copper in very high concentrations can be problematic. I know it more from a tox standpoint, where there's certain pesticides that you'll see, or herbicides that are copper based, that can be problematic, but this is such a small amount in comparison to something like that, right? But granted, copper is a normal thing you would find in your body anyway, right? It's not like lead or cobalt or things like that really have no physiologic business in the body. At least copper is something that it's a trace element that we need to be getting in our system anyway. So I'm not aware of any kind of long-term issues like neurotoxicity or any other issues like that. Certainly we've seen problems with metal on metal prostheses, or not prostheses, hip joint replacements. Yeah, thank you. So the cobalt kind of rubbing on one another for long periods of time, we're seeing neurotoxicity from that wasn't witnessed. Yeah, nickel and cobalt. Yeah, so a lot of problems with that, which is why we're kind of moving away from those. Yeah, but I'm not aware of any long-term problems from having copper there.
Do metal testing. There's some surgeries where.
Yeah, there's a lot of. Yeah, that's kind of a tricky topic because it's a question of okay, we know a cobalt level should be 0 in a person, but if it's high, what does that mean? What's your risk? Are they going to go in and take it out? Who knows? So lots of questions about that. Hopefully, we'll find some more stuff out in the future. But so that's it for contraception. Any other questions on that specifically? Yes, ma'am.
So with the ovulating, how often can you tell your patient to do that?
They can do it whenever they like.
They can keep doing it, just never know.
Well, if you think about it, some of the birth control products, I'm gonna actually upload. I don't think I did it yet, but I'll upload a PDF that has a lot of different birth control products. And I didn't post it here because there's not really a lot of point to you looking at all the different brand names. But I'll post a chart that has a lot of different products on there, and I'll show you the different triphasic, biphasic products and see how they kind of differ. But there are things like Seasonique and Seasonal where they're either getting their period just one time a year or 4 times a year, and so they're taking active product 360, whatever minus a week days per year, and then having just that one period. So it's not detrimental. We haven't found any long-term effects from having patients take that for a long period of time. Because again, because they have the progestin balancing it out, when they have the withdrawal effects, it's like a normal menses. Let me get Mike in there.
With girls who take birth control, when they take
be careful.
Taking progesterone only because they're contraindicated for taking an estrogen pill, and they have that for bleeding. Is there any option, or they just kind of have to do it?
You kind of see how it's going to go for them. So you kind of give it 3 months or so to see how they can tolerate it. Like some people will try like, Depo-Provera and they can't tolerate it, and so they'll switch over to something else, right? So maybe something like the Paragard or maybe something like Mirena might be a better option for them. Really just depends on the patient. Yep.
How do you deal with the breakthrough bleeding for someone like season week and they only do it 3 or 4 times a year?
That you need to kind of look at, are they getting a sufficient enough estrogen dose or progestin? So they may not be a good candidate for that specific product, and we need to have them. And if you think about it, like you can prescribe it to where like even though they're not getting like the Seasonique specifically, like they can take it like they're using that. So you just tell them just never use never use the placebo part of it and just keep taking the same pack, right? You can give them enough, they might have issues where like with refills or something like that with their insurance, but usually like a prior auth or something can kind of get around that. But yeah, so basically they can just, if they need to switch to a different product, you just gotta switch them.
I know people that crush birth control pills and put them in their shampoo for hair growth. Is that true?
I don't know, is that?
I didn't do it. Calm down. Swear to God, I didn't do it.
Yeah.
I have no idea. I've never heard that, but that's interesting.
Like, would you have any like systemic effects from it, anyways?
I can't imagine. It's not like you're putting a really lipophilic medium for it to be absorbed very well. Because again, you put it on, you wash your hair, and you rinse it off. So I don't know how much will really stick around for very long. Interesting question. If you find any articles out there, please let me know.
And I googled it. It's no scholastic stuff.
Well, that's the key there. You might find some non-scholastic things. Anyway, any other questions? All right, I'll give you guys a 10-minute break, and I will continue on after this. Okay. Yeah. So any other questions from the first half? You guys are contraception wizards now. You guys will be able to, yeah. You guys might need to study a little bit more for this stuff. It took me a long time to really understand female endocrine stuff. A long time. Still learning quite a bit. Anyway, so we're going to talk a little bit about agonists and antagonists, some of the drugs that can kind of affect this whole process here. So again, remember how everything is kind of coming downstream from the hypothalamus down to the anterior pituitary, which is releasing FH, LSH, and that's stimulating the ovaries to produce estrogens, progestins, things like that. Other enzymes to keep in mind here are things like aromatase. This will be really important for some treatments for breast cancer and things like that. And this is an important enzyme for converting things like testosterone and other androgens over into estradiol. Right? Remember, that's one of the major estrogen products that the female body produces. So again, this would be one way to definitely kind of stop that whole process by inhibiting that aromatase enzyme. Right? So we'll look at some of the different drugs that can be used to either stimulate this process or in order to inhibit it. So first we'll talk about selective estrogen receptor modulators, or otherwise known as SERMs. Have you guys covered any of these?
Yep.
Okay. Tomorrow's test will be on this, right? Yep. All right. So the first one we had was tamoxifen or Nolvadex. So can you guys kind of describe what a SERM is? It's a selective estrogen. Thank you so much. That was a great description. How about practically, what does that mean?
Well, it can like increase estrogen in the uterus, but then decrease it to the breast.
Right. So it acts as estrogen because it's agonizing the receptor itself. So it's not necessarily changing levels of estrogens, but it's acting as estrogen itself. It will be an agonist in some tissues and an antagonist in different other tissues. Right. So this will be important when you're kind of comparing the drugs because some of them will be, say, like an antagonist in the bone. And so if I were to antagonize estrogen receptors in the bone, what do I run the risk of? Osteoporosis, right? So we're going to be looking at ones that act as agonists in the bone, maybe are antagonists in the breast tissue, and vice versa. So we'll look at some of the different drugs and how they are working effectively. And a lot of this is coming back down to, if you guys remember the mechanism for these hormones, they're binding to these different estrogen receptors, right? So they usually forms a dimer, can have estrogen receptor alpha or beta, and they have different tissues will have different makeups of these receptors, and thus you'll find different receptors that the drugs are binding to in the breast tissue versus the bone, which is why you can have different amounts of activity because the drugs are interacting with these receptors a little bit differently. But the first one we had was a tamoxifen or Nolvadex. So this is a competitive partial agonist and basically an inhibitor of estradiol, right? So if this was filling up the receptor space and preventing estradiol from activating it, because this is only a partial agonist, you end up having kind of diminished estradiol effects. Here you would see that act as an agonist in the bone in the endometrium, but an antagonist in the breast tissue. Okay. So again, we don't know the full mechanism here, but it's thought to be due to some of these co-regulators that are being recruited. And again, based on those heterodimers, so based on what type of estrogen receptors is binding to, that allows for different actions in the different tissues. So typically we'd use this drug for things like palliative care of breast cancer in postmenopausal women. Again, because it's antagonizing the effects of estrogen in the breast tissue, prevents that kind of positive effect that estradiol normally has on those tissues. And then we'd actually sometimes use it as prevention of breast cancer for those women we know who are at high risk. So they have like a primary relative, like their mom had it, then we know that they're at high risk for developing as well.
Why palliative?
Because of the negative effects we're going to see with this drug. So it wouldn't be like kind of a first-line therapy, because we'd be using, because it's not going to get rid of the breast cancer tissue by itself, right? It'll help to kind of slow it down a little bit, but we got other chemotherapeutics we're going to use in order to treat that.
So if it's like really bad.
Yeah, so it's like inoperable. Yeah, we're this is going to be this is what the patient has is terminal. We can use this to kind of slow things down and hopefully keep them around for as long as possible. And again, some of the nice things about drugs even orally like this is they get systemic. So if you were to have things like metastases to different tissues, you would also be antagonizing that tissue, say if it got into the lungs or if it got into the bone or wherever else it might go to. Again, it's an orally administered medication, and the biggest side effect you're going to see with this is going to be hot flashes. Makes sense because it's acting as an antagonist of some of these tissues. So it's kind of mimicking menopause for these patients, right? So especially if it's acting as a competitive antagonist by only partially agonizing those receptors, and you can see where that can be problematic for those patients, that they're still producing some estradiol. So also some other uses you can see with this, it helps to prevent loss of lumbar spine bone density. So it would be good for your patients you're worried about osteoporosis in. Saw some improvements in their lipid changes, again due to the way it was acting in the liver tissues. They ended up seeing lower atherosclerosis risk. And then related back to the partial agonist activity, you did see increased risk for endometrial cancer and vaginal bleeding, right? Because it's still acting as a partial agonist in the endometrial tissue, so we're seeing some hyperplasia and some bleeding associated with that. You still see some risk for thromboembolism as well. Okay, so again, it's not pure estrogen antagonist. You're still getting some of these effects from the partial agonist effects. So that was the first one we had. That was tamoxifen. Since then, we have raloxifene or Evista. This one is going to be a partial estrogen agonist antagonist, so it's still a SERM, but you're going to find that it has estrogenic effects on the lipids and the bone, but it's not going to stimulate the endometrium or the breast tissue right here. So now you don't really have the endometrial cancer risk. You don't really have the same abnormal bleeding that you're going to see. And so this could be good for prevention of postmenopausal osteoporosis, because it's good effects on the bone, but it also can be used for prevention of breast cancer in some of the high-risk women. Or omens, if you will. If your omens get breast cancer, you can treat them as well. It's one of those things where they don't catch the misspellings there on the slide. Yeah. Anywho, another drug we have that acts kind of as a partial agonist is going to be clomiphene or Clomid. You guys know where we use this one most frequently? Stimulate ovulation, yeah. So this one is it's an older drug. It's a partial agonist, but it's binding to those hypothalamic estrogen receptors. It actually inhibits the negative feedback loop. So basically, by only being a partial agonist at those estrogen receptors, what is that going to do to LH and FSH? You're stopping that negative feedback loop, so it's going to increase release of LH and FSH. That's kind of working to stimulate development of the follicle and hopefully for implantation. Other drugs we have, one called danazol or danocrine. This is a weak, has a little bit of progesterol effect, weak androgenic effect, and some glucocorticoid effect. We use this one primarily to actually suppress ovarian function. So this can actually work to prevent mid-cycle surges of LH and FSH. And so you can use this one most frequently to treat things like endometriosis. Those patients usually end up finding some improvement in their effects, in their symptoms, usually within 3 to 12 months or so. Sometimes you actually see it used in other allergic or hematologic conditions. So if you have things like hemophilia, if you had Christmas disease or factor deficiencies, you guys know what ITP is? Thrombocytopenic purpura. Yeah, it's idiopathic thrombocytopenic purpura. So sometimes you can use that to help kind of trigger off the platelets. Angioneurotic edema. So lots of different cases you may see this one. Due to its glucocorticoid and androgen effects, this is where you see things like weight gain, edema, and all of that associated with that. So not one used super frequently as far as I've seen, but you may see it used for those purposes. Some other drugs. These are aromatase inhibitors. So we have anastrozole or Arimidex. This one again is working to block aromatase, so that it prevents that conversion of testosterone over into estradiol. So this is going to be good for women, and because you see such big drops in your estrogen levels, again, this can induce menopause in some women. So you do want to be careful of things like hot flashes and whatnot. You worry about risk for osteoporosis, but this is better for women who are resistant to tamoxifen, right? So you're giving them tamoxifen for, say, for breast cancer, for palliative care, and they're still not improving at all. They're still having too much estrogen activity there. You give this and basically just drop their levels down significantly to prevent any further activation of those tissues. Other ones we have like letrozole and exemestane. They're going to be working very similarly to anastrozole. And so basically you end up seeing fewer pro-estrogen effects here. So again, you don't really have the positive bone effects. You also don't have the endometrial effects as well. So that can be one thing you see with that. But it does have a bigger risk for fractures. It's one of the main drawbacks for these drugs. And that's it for the OB GYN section. Any questions?
For the Arimidex one, we were told that if they were not postmenopausal yet, that you could use gnrh to put them into menopause while they're on the Arimidex.
That makes a sense.
Is that something?
So why would you do gnrh?
Just to put them in menopause so that they don't have.
Right, so again, that's activating that negative feedback loop. So basically, you're suppressing them. So you're basically, that's just another way to inhibit that production of new estrogen, right? Because by giving the gnrh, you're kind of dropping down their secretion of LH and FSH. So that's where you're going to get that from that standpoint. So basically, they're kind of doing the same thing. They're working at different stages in the process. Any other questions? All right, so to move on to a more sunny topic, let's talk about cancer. I'm a toxicologist by trade, so I don't like to give poisons to people, so this is why I don't like chemo, but we will talk about it anyway. My experience with cancer is mostly going to be in the pediatric standpoint. You guys know what kind of cancers kids most often get? Yeah, leukemias, right? So usually cancers of the blood, right? So you see lymphoma, see leukemia, a lot of leukemia. You still get some solid tumors, so you may see like osteosarcomas or rhabdosarcomas, things like that. But by and large, you get some brain cancers. But again, I am not a super huge expert on chemo. Like a lot of people will, like you have the chemo pharmacist, and that's all they do day in and day out. So there may be some questions I cannot answer, but we'll at least talk about the basics and go through the major classes of drugs you may see being used for these patients. And even if you don't work with chemo patients very frequently, it's still important to be at least aware of this. So if you have patients who come in on these drugs and you're seeing side effects from this or downstream effects, you can at least be aware of it and kind of anticipate some of this stuff. Okay, so what is cancer? So that's an astrological sign. Yeah, irregular, unchecked cell growth, right? So basically it's this altered cell growth, cell division, and differentiation. So basically just things are just kind of replicating just ad infinitum forever until it basically takes over your whole body, right? So you end up getting this mass of tissue, and it's not being controlled by normal physiological process. So like, how does your body normally tell cells to stop growing? Tumor suppressor genes, that's a big one. So things like the p53 gene is a big one that is lost in a lot of these cancerous cells. You end up having increased growth factors. You end up losing a lot of those negative feedback loops that have more growth factors. Some of these cyclin-dependent kinases are upregulated, and they also lose that contact inhibition. You guys remember what that is?
Yeah, when the cells touch another cell, it activates the growth.
Yeah, they get too crowded. They're basically like, okay, we don't need to grow anymore, but these cells lose that, and they're like, all right, we're just going to keep growing until we kill somebody, right? So these are a few years old, but again, it still is probably true, at least as far as the most common new cases of cancer, and then also the ones that lead to the most death. Obviously, things like lung and bronchus cancer are going to be the most deadly ones. Prostate and breast cancer. Prostate cancer is usually pretty treatable for the most part, but again, it's those patients that don't get seen for a while, and it's very prevalent. There's a lot of patients who end up developing prostate cancer. Yeah, and so again, a lot of these things can be affected by lifestyle modifications. So again, prevention is always going to be the best cure for these patients in a lot of cases. But notice mostly for adults, you see a lot more solid tumors they end up treating versus like in kids, I mentioned it's a lot of blood-based tumors. So you see a lot of leukemias they end up treating. The drugs will have some overlap, but there are certainly some ones that we use more likely in kids than we do in adults and vice versa. But you can also see here in this slide how the 5-year survival rates are starting to improve. A lot of this is both due to things like better surgical intervention, better radiation techniques, and also better medication. So, and again, we're always doing new studies to look to see the best way to treat some of these cancers. Because again, cancer is a relatively rare thing as compared to something like diabetes or compared to hypertension, so it's hard to do like giant massive studies for cancer patients. So for instance, we have the Children's Oncology Group, or the COG, and so basically every single patient that gets diagnosed with cancer that we treat, say at Nemours, they all end up going into a COG study. Right, so basically they say, okay, we're going to go ahead and do this study. We're going to be randomized to this arm versus this arm, and we're going to get this drug for this many days versus that drug for this many days, right? And so you can compare outcomes to see which one's better, and hopefully end up coming out with a net better treatment for them in the long run. So there's still a lot of studies being done to see what the best way to treat these patients are, and you're probably going to see continued increases in survival rates. Okay, so initially, when you're looking at cells and whether or not they're considered really cancerous, there's a couple of different stages to this. The first one kind of being hyperplasia. This is basically just an increase in the size or the number of the cells. So basically their function remains pretty much unchanged. You still have the same type of skin cell or muscle cell or whatever, you just may have more of them, right? Usually this is a reversible phenomenon, right? So think about muscles you work out. If you work them out all the time, they're going to get bigger. If you stop working them out, they're going to get smaller, right? It's a reversible process of hyperplasia. If you're like me, you just stop working out altogether and then you just get fat and that's no good. But anyway, you also have metaplasia. So this is going to be more of a change in the actual function of the type of cell that's there. It's an adaptive substitution for one type of cell for another. So you can see this, especially if you think about like chronic smokers. Their lungs are and their whole respiratory tract is constantly being exposed to very hot, heated gases, a lot of noxious kind of stimuli. And so what happens to all those ciliated cells that normally help to clear mucus? They're not there anymore. They get differentiated for other things like maybe some scar tissue and things like that. And so you actually end up having loss of function from a lot of cases. And so again, this may be a protective response. You may see some loss of function. Calluses is another good example of this, where you get a buildup of dead skin cells with constant irritation of for instance, like when I was in drumline in high school, like I always got massive calluses in our hands from the drumsticks, right? That was the coolest thing I ever did in school. And that still was not very cool. So then the next step would be dysplasia, and so this is where you lose this kind of uniformity, start to lose some orientation of the cells. This may be reversible in some cases, mostly it is, but again, this is just continuing on down that road towards kind of unchecked growth of these cells. And then finally we get to neoplasia, and so this is where they're having uncoordinated growth, losing a lot of those responses to suppressor genes. Normally P53 is really important because it triggers apoptosis, which is, it's like cell suicide basically, right? So it triggers off that cell death. You end up losing that function. You also have this immortalization of these cells. Have you guys heard of telomerase? Yeah, what is that? Yeah, so basically at the end of all your genes, you have all this kind of extra junk DNA that as you continue to divide, it gets cut up, so you still maintain function of the genes, but these cells end up kind of losing that. So at a certain point, every cell is not going to be able to continue to replicate because it ends up having too much of the DNA being cut off, but these cells lose that function, so they end up basically becoming immortal. They're the Highlanders in your body, and they keep growing forever, right? Except there's not only one, there's usually billions of them. It's not good. So again, your tumor cells you can either consider be benign, where they're kind of localized, they may be enclosed in the kind of a fibrous capsule, and these are able to be removed surgically in a lot of cases, and usually it leads to pretty good survival rates. Versus your malignant ones, where they start to spread, they go to other tissues, and no capsule, they metastasize, so they start to kind of proliferate in different tissue sites, and usually leads to the death of the patient if left unchecked. And of course, we can grade the tumors based on kind of how advanced they are. So grade 1 being, closely resembling the tissue of origins, usually pretty close to the normal tissue, and still retains its function. As you get to grade 2, 3, 4, like you start to lose more of that. You start to see less differentiation in the cells and just kind of this unchecked growth continuing to occur. And so notice here we have increased and enhanced mitosis. Mitosis being? Yeah, cell division. And so this is going to be really, really important because you're going to find that chemotherapeutic drugs, are they specific to treating cancerous cells? No. They're not, right? So for the most part, they're going to be treating both cancerous cells and normal cells, which is why you see so much toxicity with these drugs. But if you can target the cells that are actively undergoing mitosis, you can hopefully target those cells more effectively and get rid of the cancerous ones while leaving the other ones relatively unharmed. And so that's going to be a big principle when we look at the different drugs we're going to use and how they target different spots in mitosis. So some of our principles of therapy when we are treating these patients is one, just a single clonogenic or unsuppressed cell it has the ability for unlimited proliferation, right? So if you leave one cell behind, that's enough to continue forming a tumor, right? So the idea is you want to kill every single tumor cell possible in order to prevent further growth. You're going to find that the different tumors are going to have different growth patterns, and that can change based on the stage of disease. So as they start to get less differentiated, they start to metastasize, you may see that their growth patterns are going to change. And so some may become more slow growing, some may be more quickly growing. So if you think about things like prostate cancer, is that pretty slow or pretty fast growing tumor? Pretty slow, which is why it's very easy to treat for the most part in comparison to some of our other types of cancer. But if you think about like a leukemia, your blood cells are always replicating, right? So it's going to be more likely to see more problems associated with that. So, and again, all those cells being in different stages of mitosis, how we target those drugs are going to be important. And so you can actually see how our doses and our durations of therapy can change based on that. So, also looking at things like well-differentiated versus non-differentiated cells, so comparing things like early lung cancers or colon cancers, if you can end up targeting those cells a little bit more effectively, as they lose the differentiation, it can be more difficult to target them. And we talked about the slow versus fast-growing tumor, and then obviously localized versus disseminated. How might that change our treatment? You do radiation, you can do surgery, yeah, so you can remove it, right, if it's all localized in one specific site. But if it's like leukemia, disseminated everywhere, right, so you can't really do that. So that's why we see a lot more drug therapy associated with those rather than specifically using things like radiation or surgery, right? So think about where the tumor is actually located at, and then also the heterogeneity of the tumor, so just how differentiated they are. If you have multiple multiple cell types, that can make therapy more difficult as well. Yes, ma'am. We'll talk about some of those reasons in just a few minutes. A lot of it could just be the fact that you're not able to eliminate all the cells, and so there's always going to be some small amount of residual that may not be suppressed by your body's normal immune function and inflammatory processes and things like that. Some of it could be related back to resistance. So you'll actually, just like bacteria become resistant to antibiotics, same thing's happening here, right? So you can think about antibiotics as being chemotherapy for bacteria. We're basically doing the same thing, and so your cells want to survive, and so they're going to do things to try to make that happen. Okay. Now cells undergo what we call Gompertzian cell growth. So you can sound really fancy if you go and you drop that word for your friends. Basically, each tumor takes a constant time to double its size. Okay. So the time it takes for one cell to divide into two will be the same time it takes for two to divide to four, so on and so forth, right? At some point, though, you're going to see that will plateau. And why do you think that plateaus?
Sufficient nutrients.
Yeah, absolutely. So you need space, you need nutrients in order to keep growing. So at some point, the tumor will kind of outstrip its own nutrient source. You may run into problems with that, right? So it'll have an initial very rapid growth, and then it will plateau out at some point, right? So that's one of the big things we're going to see with this, and it's important when we're looking at dropping that cell burden and seeing how that kind of affects the growth, or actually the growth pattern. So you can imagine here, if you were to leave the tumor cells to grow unchecked, you can see here how it just kind of goes. And notice here, like, you already probably have a pretty big cell burden by the time you actually diagnose the cancer, right? So 10 to the 8th power number of cells floating around. It's quite a few cells you already have that are cancerous that you need to remove at that point. So you may not notice it until maybe you get to like another order of magnitude higher, and then eventually they just keep going. Eventually lead to death of the patient, right? So what we're going to call here, or what we see here, is going to be this first order cell kill. And so essentially when you do an initial therapy, you're going to get some fraction of the cells, right? So think about, even if you got 99.9% of the cells killed in a given therapy, if you started out with 10 to the 12th, how many do you have left at the end of that?
A lot.
still have 10 to the 9th left, right? Like you still have a lot of cells left. So for instance, even if I were to say I was diagnosed at here and I end up doing surgery and I removed a big chunk of those cells, I still have a lot of cells left over that can still grow, right? And so this is where you're going to see combination therapy, where we may be doing things like starting off with a surgical intervention, and then we use radiation or chemotherapy to try to get the residual cells. You know, even if you got 99.9% every single time, there's still going to be some kind of residual. So we're hopefully trying to get the cell counts down low enough to where the body can kind of take care of itself. But that may or may not always happen depending on the type of cancer, how differentiated it is, if it's metastasized, all kinds of different things. So, and again, if you can kind of look at the different cell, how many cells there are and kind of what that equates to, you know, so 10 to the 9th cells being about a gram or so, and then you get, you know, very, very large tumors, 10 to the 12th being about a kilogram, you know, 2.2 pounds at that point, so pretty big. And so you can see there that surgery, you can knock it down pretty low, but then you still have a lot of cells left to kill. So you can imagine this, so that would be kind of a surgical intervention with, like, say, like chemotherapy afterwards. Like this may be something like radiation or chemotherapy by itself. You know, so this might be better for like a leukemia or something like that, right, where you can't really use a surgical intervention to get rid of that. So just think about the different modalities on how we can combine this together. So obviously treatment should revolve around removing the tumor if possible. So surgery is going to be great for well-localized, well-differentiated tumors. That way you can just kind of go in there, just cut it all out, and hopefully you're done, right? Hopefully not leave any cells behind. Radiation therapy is good for localized tumors that are not easily removed. Do you guys think of any cancers you might use radiation therapy? Might use it for pancreas. Like brain cancers, you might use some radiation. There's actually some brain cancer that actually will go in and put like radiation, like kind of like laced wafers almost, like into the actual brain to get local tissue kills and things like that. So again, radiation can be good for localized tumors you can't really easily get to or you can't remove necessarily, right? So it could be good for like really deep tumors or something. Again, I'm not an expert in radiation therapy, so I'm just kind of quoting what I've heard previously. But chemotherapy, which I'm a little bit more familiar with, this is going to be better for killing these cancer cells systemically because we're administering them systemically, and you're going to find that also we're going to have more systemic effects associated with this, right? Certainly radiation has its own side effects, certainly surgery does, but these chemotherapeutics are going to be affecting the whole body for the most part. And for the most part, we can look at our adverse effects being a side effect of treating or affecting all the rapidly dividing cells. So if you're thinking about rapidly dividing cells in the human body, what would you think of? Well, the cancers, but hair cells, right? So if we target all of our hair cells, we see alopecia, absolutely. So what other cells do we have that rapidly grow? Skin can be affected, hair, so I mentioned hair. Bone marrow is affected as well, right? So that affects all of our rapidly dividing blood cells. GI tract's a huge one, right? So all those epithelial cells, the mucous membranes take a huge hit as well. So that's where you see a lot of these side effects associated with rapidly dividing cells being targeted as well as the rapidly dividing cancerous cells, okay? So again, we kind of talked about this and how you can combine the different modalities together. So looking at basically what we want to do when we're giving chemotherapeutics is you want to maximize the drug concentration and the exposure time in order to kill as many cancer cells as possible without killing your patient, right? So it's a delicate balance between trying to keep your patient alive and relatively healthy versus trying to kill all those cancerous cells. And so you got to maximize the benefit versus the risk ratios, and then consider all of the very significant comorbidities and toxicities you're going to see associated with the cancer treatment, right? So what happens when you get myelosuppressed?
Gotta be careful.
Well, careful what?
Infection.
Infection, right? Absolutely. So you're immunosuppressed. So these patients are treated almost essentially like AIDS patients because they are so immunosuppressed at a point where they get really neutropenic. They develop a fever. Guess what? They're going to be on. They're getting admitted. They're going to be put on broad spectrum antibiotics because again, a lot of times they may not mount the same kind of response, or they may not seem sick. Fever might be the only thing they really show you to show that they have an infection, right? So the immune system is kind of really diminished. So usually infection is the thing that ends up killing these patients, right? So if they're on in the middle of their chemotherapy, they get a really nasty infection. They're more likely to get more resistant bugs because they're on multiple courses of antibiotics. They're more likely to get fungal infections, more likely to get viruses. It's bad news, right? And so that's why you got to be careful with things like, we don't want to give them, like the kind of flowers or fruit that they have delivered to their room, right? What kind of fruit do you want to give to a myelosuppressed cancer patient? You can't give them an apple, right? You can't, yeah, so canned fruit might be good, or something like that to peel. Yeah, they can peel, so like an orange might be okay, or like a banana or something, but you have to think about things like this and what kind of sources for infection they have, okay? Do you know which way you do not want to check a check a temperature on a neutropenic patient? Why not? Yeah, you worry about perforation, right? So you worry about perforation, translocation of those GI bugs. Guess what? Now they got a really bad septicemia, they're dead, right? So little things like that to consider when they are this sick. And we did it to them, right? Technically, yeah. So again, it's all risk versus benefits for these patients. And so usually we like to do either high dose with an intermittent schedule. So essentially we give them a really big dose of chemo drugs to really knock them down, to really kill as many of those rapidly dividing cells as possible, and then you give the body time to recover. You're hoping that the body's natural normal cells are recovering at a faster rate than the cancer cells are. Okay, so that's one way to do it. And then in some cases, especially for slower growing types of tumors, you may want to give drugs over a prolonged period of time to make sure you hit as many of them as they get into certain cell cycles as you can. I'll show you more details on that in just a minute. But again, it depends on where the tumor is in the growth curve. If you can catch them early on, when they're in that really kind of rapidly dividing phase, you're more likely to hit a lot of them in mitosis versus if they've kind of plateaued out and not many of them are growing anymore. Okay, so you have to consider where they're at from that standpoint. So, do you guys remember this from biology? Yeah, this is fun, right? Yep, I see a lot of blez and bleh. Yep. Okay, so this is our cell cycle. Getting back to basics here. So again, we have several phases of the cell cycle, right? So normally we have our G1 phase. Well, actually, we'll start with G0. G0 is what? So resting, this is our cells are just kind of just trucking along, just doing their thing, doing whatever it is they do, right? Then you have the G1 phase, right? And this is where they're going to start to synthesize things like nucleotides, right? They're getting ready by generating new components of DNA and whatnot, right? Other cellular components get built here as well, okay? Next, you have the actual S phase, where you have DNA synthesis actually occurring. So again, they're taking all those nucleosides and they're actually putting them together and forming new DNA. Next, we have the G2 phase, which is going to be where we start to have protein synthesis, mitotic proteins start to be made here, and then finally get to the M phase, which is the actual replications, where the actual mitosis is occurring here. And then it goes right back over into those phases. So normally a lot of cells will go through this process, and then once they kind of get those, that P53 gene kind of gets activated, or if they have those, those contact receptors are working appropriately, they'll just kind of replicate until they can go into the G0 phase and they're fine, right? These cancer cells, they're constantly dividing, they're constantly going to be going back through this cycle, and so you can see as you get more rapidly dividing cells, if you can do things like, if you hit a lot of them in the mitosis phase, you can kill a lot of those type cells by preventing that process here. Or if you can trigger them when they're in the DNA replication phase, if you can actually inhibit DNA replication, you can end up stopping the cells from growing, and then eventually they get so much damage done to them due to prevention of DNA replication, they eventually will just die off, right? So this is the things we're trying to do. We're trying to trigger cell apoptosis by damaging the components to prevent them from replicating. So, yes, ma'am. You'll find that different drugs work at different sites. So you may actually combine different drugs that are working at different cell cycle components, right? So you might find some that are working during G1 phase to actually block nucleoside production. Some of them are working specifically at S phase. Some work at the M phase, So we like to combine multiple drugs usually to work on that, okay? So this kind of goes through kind of what we just talked about now. But again, those that are rapidly dividing are more likely to hit in these active phases of replication, more likely to be treated with our chemotherapeutic drugs. Okay. Remember, anti-cancer drugs are not going to be selective for tumor cells. They're affecting human cells that are rapidly dividing as well. Okay. So, again, growth fraction is just going to be that term for the proportion of cells that are actively dividing. So we want to get tumors when they're in a high growth fraction. So the more that's growing, the more likely we are to hit them. And you're going to find the S fraction will sometimes be referring to the percentage of the cells that are actually in the S phase, right? So the more cells that are in the S phase, the more likely they are to be very aggressive because they're actively getting ready for that mitotic phase. And then you look at the doubling time, which is just that time necessary for the tumor to double in volume. So early on, the doubling time would be very short. As it gets higher or gets bigger, it's going to start to slow down as it starts to outstrip those nutrients. Again, short doubling time means a more aggressive tumor. Okay, so things we can look at as far as designing our regimens here. So we like to use combination therapy. So it's very rare you'd see a patient just on one chemotherapeutic drug. This helps to minimize resistance that our cells will develop because, again, if they're rapidly dividing, they're able to generate new mutations, which may make them more resistant to our chemotherapeutic drugs. Also allows us to use lower doses of all the drugs to limit toxicity. And then you're going to find we use a lot of adjuvant therapy. meaning lots of drugs to treat or minimize the toxic effects. So a lot of antiemetic drugs, and we'll also include a lot of drugs used to help stimulate the bone marrow. So what you'll find is the patient will get a course or a cycle of chemotherapy. We'll give them big doses of things to really knock down their immune system, knock down their leukemic cells as much as possible, and then we give them growth factors, and it'll help stimulate growth back of normal cells. Okay, so a lot of times it's really just a cycle of knocking them down and then trying to pick them back up, and hopefully getting more healthy cells and more cancerous cells.
Is that just for kids or is that for adults?
You can see it with adults too. So if you have like adults that had, because all these patients are going to be getting myelosuppressed, right? So this can be used for pretty much any of them. You'll find that some regimens are more likely to cause myelosuppression than others, and so you may see it more associated with those than not. But almost all these patients are going to be antiemetics, and a lot of them. So we'll look at those regimens a little bit later. So again, early detection obviously is going to be our key to treatment as best we can. So patient education is always super important here. Make sure they're screening like they should be and preventing it in the first place. Okay, so again, as far as toxicity goes, we're killing rapidly dividing cells. So we mentioned this. We're going to be targeting those cells that have the highest growth fraction. So that's going to be our neoplastic cells, which is the intended effect. We're also hitting our bone marrow. It's going to cause myelo and immunosuppression. The GI tract, meaning they're going to get oral and intestinal ulceration. Do you guys know what you call it when you have kind of those sores that start developing in the mouth? It's not herpes. They could be at risk for herpes. It's not really the same as canker sores as aphthous ulcers, but they're called stomatitis. Yeah, stomatitis is the term we use for those patients. So mucositis, stomatitis, that's kind of what we're referring to, and they end up getting those kind of sores in the mouth. And if you think about it, like you have a young kid. Again, I always go back to pediatrics. That's what I know. But you have a young kid who's getting treated with chemotherapy, and they all these sores in their mouth. Are they going to want to eat? Probably not. So now you have to worry about nutrition, right? So maybe some of the patients have to go on TPNs now because they're not able to eat because their mucositis is so bad. So lots of different little factors you have to consider for these patients. The hair, obviously, the alopecia can be a big impact on their quality of life. Anyone losing the hair would probably, and it's all over the body too. It's not just like the hair on their head. Eyebrows, all the fine body hair, and they end up losing from that standpoint. And then also the reproductive cells take a hit as well. So decreased sperm production and menstrual irregularities are very common with this in addition. So. Some of the ways that your cells can generate resistance to some of these chemotherapeutic drugs are the same way we would see with antibiotics. So they can do things like, if the drug is not able to get into the cell, then that would lead to be less effective. So they can do things like decreasing the uptake of drug, or if they metabolize it more quickly, or say if the cell is able to generate, or if they're able to repair DNA more quickly, things like that. So you can find that over time they may develop resistance to some of these drugs, necessitating switching out to using a different type of therapy. So just be aware that is one possible thing you may run into with some of these patients. Okay, so we're going to get into the drugs now. And so the main two types you're going to run into are going to be synthetic and then natural chemotherapeutic drugs. So you find that, and I'll point them out, but a lot of the chemotherapeutic drugs we have actually come from natural sources like plants. So next time someone tells you that you can smoke pot, it's okay because it's on the earth and it must be good for you, you can be like, well, so are these chemotherapeutic drugs if you have cancer. Also, cyanide comes from peach pit, so take it for what you will. Yep. So the first kind of group of synthetic drugs we'll look at include things like the alkylating agents. These specifically are going to work to alkylate purines and pyrimidine bases, meaning that once they alkylate those, they actually will block DNA synthesis. I'll show you some pictures of what that looks like in a second. And then we'll also have drugs called antimetabolites. These are going to be structural analogs of some of the other nucleosides and things like pyrimidines and purines, and basically they get incorporated into DNA and actually prevent further replication. So both of these drugs are working specifically to block DNA replication just via a different route. And some of these are going to be kind of similar to what we saw with like some of our HIV drugs. Alkylating agents are kind of a little bit different. Those are kind of more like some like your antivirals, but we'll look at those in just a few seconds. Next, some of the natural products, we have some plant alkaloids. Some of these are going to be working on affecting things like mitotic spindle formation. Some of them will be affecting the enzyme topoisomerase. You guys remember what topoisomerase does? Helps with kind of cutting those single strand breaks in the DNA to allow unwinding and winding of the DNA, right? Because again, usually your DNA is really all wound up tight, and you can clip those and then cause some relaxation of that. You guys remember what antibiotic inhibits topoisomerase? Just guess. It's a fluoroquinolone. Yeah, fluoroquinolones. So they actually inhibit topoisomerase as well, right? But they're targeting a different topoisomerase that are affecting bacterial cells versus affecting our cells, right? So here we're affecting now human topoisomerase. We have a group called the antibiotics, which is actually kind of misleading. But basically, these are going to be binding, or actually a new term, intercalate. You guys heard the term intercalate? As, huh? Yeah, it's kind of like, yeah, that's basically what it's doing. So it's one of my favorite medical words, but basically it's kind of like jamming itself in between the DNA in order to cause strand breaks and things like that. So we'll talk about those drugs. And then we'll look at some natural products, which you'll find with some of the more biologic products, you actually have higher specificity for cancer cells. And so you actually end up having a better time with things like toxicity. So we have biological response modifiers, hormonal agents, and also immunostimulants. So we'll look at some of those a little bit later on. First off, look at the alkylating agents. So, be aware of these drugs. We'll talk about specific. So, when I'm writing test questions for this stuff, big thing is to know the mechanisms of action, be able to identify the drugs and how they, what mechanism they fall into. And if I talk about specific side effects associated with these, be aware of that. So, if I key in on something like, oh, this causes hemorrhagic cystitis, that is unique to this drug, I should probably know that. Or if this one has an antidote for this particular side effect, I should probably know that as well, right? So those are the kind of things I key in on. And that's the kind of things that you should key in on when you are seeing patients, right? When you're actually seeing these patients and be like, oh, you have really poor lung function. Perhaps it's because you had busulfan when you were getting treated for cancer all those years ago, right? So different things like that you want to be kind of be aware of. So anything else with that? So those are kind of the big things to remember with chemo drugs. And again, if I say like, oh, it causes nausea, vomiting, myelosuppression, like that's not super unique. Like most of these drugs are going to cause that, so don't get too hung up on remembering which ones cause nausea and vomiting, because it's probably all of them. But I will focus on some of them that have, we'll talk about things like emetogenic potential, and it's the ability to cause vomiting. And some drugs have very high emetogenic potential, some have very low emetogenic potential. Like I have that very high emetogenic potential around women usually. But yeah, you'll see that the drugs come on a scale, and that actually is going to be important when you're talking about the type of antiemetics you're going to use. Because for some things that have high emetogenic potential, you're going to be using like 7 or 8 different drugs just to treat the nausea and vomiting versus things that have low emetogenic potential, right? So we'll look at that a little bit later on as well. Okay, so the nitrogen mustards, don't put these on your hot dogs. It'd be pretty gross. But these actually come about from, you guys know where the nitrogen mustards come from originally? Mustard seeds and also mustard gas. Yeah, so we'll talk about mustard gas. So, so some of the drugs that fall into this category, the more common ones that I see being used clinically include things like cyclophosphamide. You'll see ifosfamide, and then some of the other ones like chlorambucil, methylene. Keep in mind that these drugs oftentimes will have nicknames very similar to what we saw with like the HIV drugs. So chemotherapy is another really big one that's error prone, because a lot of those practitioners talk about their drugs in terms of the acronyms or the nicknames for them, right? So for instance, like ifosfamide, they always call it ifos. The one's always called that. We'll get some of the other ones a little bit later on, but things like carmustine or lomustine get BCNU, CCNU. So if you hear those kind of terms, just be aware to look that stuff up. Make sure you don't get things mixed up there. Having nitrosoureas, these are also going to be alkylating agents that work a little differently than the mustards. This includes carmustine, lomustine, and also streptozocin. Streptozocin is kind of unique because it actually targets pancreatic beta cells, and so one of the unintended side effects from this is, what do you think it would be? Diabetes. Yeah, so you actually induce diabetes, type 1 diabetes in a patient after giving this drug. Right? But it also can be useful for targeting pancreatic cells. And again, pancreatic cancer, deadly or not so deadly? Deadly, right? So again, could be a good trade-off.
Reversible, or
No, it'll be gone. Yeah, beta cells are not one of those ones that are super easy to regenerate, unfortunately. Otherwise, you wouldn't have so many type 1 diabetics, right? So, okay, so some other alkylating agents you can run into, things like dacarbazine, procarbazine, temozolomide. Busulfan is going to be a big one when we talk about pulmonary toxicity. Have you guys seen Chemo Man? Anti-neoplastic man?
Yes.
Yeah, you've seen that? Okay, so it's a little diagram of a guy. Yeah, he's got a B for lungs, he's going to have a C for his bladder, and C for his ears. Okay, I'm going to post a picture of that as well, but you can obviously Google that, but that's going to be good for common side effects associated with chemo drugs, okay? So if you guys have a little cheat sheet you're going to carry on rotations with you, that's a good one to have on hand, so you can see common side effects associated with these drugs, okay? And then we also have some platinum compounds, and so these are all platinum-based. You have things like cisplatin, carboplatin, oxaliplatin. There's 5-FU. we'll look at a little bit later on. But cisplatin is a fairly common one I see being used in a lot of our leukemic kids. So, in general, you're going to find that these drugs are pretty cytotoxic to these rapidly dividing cells, and these are going to be non-cell cycle specific. That's another good thing to note as well, is where these drugs are going to be cycle specific to, if they are. So again, the alkylating agents, the way they're working is actually binding to the DNA, binding those purines and pyrimidines and whatnot. And so because of that, it doesn't have to be in a stage where it's actively dividing in order to help, in order to bind to those. So it works on G1, works on the S phase. And the other thing you have to look at is all the chemo drugs that we're giving, by causing all this cell damage and causing all these healthy cells to start to replicate, what does that increase your risk of? Increase your cancer risk, right? So as you cause more mutations in these healthy cells, that also can be leading to carcinogenesis, right? They're also teratogenic, so you do not want your pregnant patients to be on these drugs, right? So you want to make sure that they are using proper protection and preventing pregnancy from that standpoint. So that mutagenic means they're causing gene mutations leading to potential cancer. These will all cause pretty significant bone marrow suppression, so again, run the risk for infection. You're going to see the oral and GI mucosa being affected here, so a lot of diarrhea, a lot of stomatitis associated with that. Again, decreased sexual reproduction, so less sperm production, amenorrhea can happen here. And then also a lot of CNS-mediated nausea and vomiting. So these drugs are a little bit higher up on that emetogenic potential. They can cause quite a significant amount of nausea and vomiting. We mentioned the carcinogenesis, so you can see secondary things like leukemias develop afterwards. And then all of these can cause pulmonary fibrosis. Okay. So basically, if you, serial PFTs is going to be one of the things you're going to want to monitor your patients for, both before, during, and after therapy as well, especially if they're going to be a long course of these. And obviously, immunosuppression is going to be associated with this as well. So we'll talk about some of these more in detail as we go on. So again, not cell cycle specific. You can see here by hitting either G1 or S, it's going to be able to target quite a few of those cells, even if they're not really in such a rapid growth phase anymore. This will be able to target them based on their mechanism. So, being alkylating agents, obviously they're going to be alkylating things, so basically they're going to bind to these nitrogen atoms of guanine, adenosine, and cytosine, which where do you find those? DNA, absolutely. So it's binding to the actual DNA that's already formed or in forming purines and pyrimidines. And so basically you end up finding these formation of crosslinks that occur with these adjacent base pairs. And so by causing that, you're causing DNA damage and you're inhibiting DNA replication. So DNA polymerase is not working quite as well, causing more damage, and then you can trigger that apoptosis, hopefully, by causing this excessive damage. So more strain breaks, you have increase in that P53 gene activity, so more activity there means more cell death, more apoptosis happening. And then also you can have misreads of the DNA. So when you have abnormal pairing of things like guanine and thymidine, you can actually have the the RNA polymerase coming along and misread it and code for the wrong protein, which can also potentially lead to cell death. Okay. Other things it can do, like depyrination, where actually remove the purine from the sugar backbone, right? So that can be leading to problems reading that as well. And then also this ring cleavage can be increased, and so you end up seeing decreased purines in the DNA synthesis phase. So not only targeting the DNA that's already formed, but also the newly forming DNA is being made in the S phase. So just an example here, you can see where mechlorethamine is able to lose these chlorine molecules here and then bind over to the guanines here and cause those misreads, cause those strand breaks, and eventually lead to that cell death. Okay, that makes sense how it's working? Okay, so I think I'm going to go ahead and cut it there. I'll be merciful and give you guys 10 minutes. Any questions before I let you guys go?
Is this on our quiz?
This will not be on the quiz. OB GYN stuff only on the quiz, and probably more focused on kind of the first half of it. But all of the OB GYN stuff could be game on there. So oral contraceptives certainly could fall on that quiz. Okay, if not, I will see you guys next week.